Hello everyone. Welcome to my video presentation today. I hope everyone is doing good in this situation. Today I will be talking about the operational planning guidelines and will also have an overview of state level preparedness and response about the present COVID-19 virus. This is a record of achievement that I have recently achieved from the World Health Organization. To start with, about 5 years ago, in March 2015, Bill Gates, in a TED talk, was seen speaking about the next outbreak for which we were not ready. He said that when he was a kid, he was worried about disasters caused by the nuclear war. He said that today, the greatest risk of global catastrophe doesn't look like a nuclear war, but it looks something like this. If anything kills over 10 million people in the next few decades, it's more likely to be a highly infectious virus rather than a war. It's not missiles, but microbes. According to him, this situation is just because we have invested a huge amount of money in nuclear weapons, but we have actually invested very little in order to stop an epidemic. On March 2015, he said that we are not ready for the next epidemic. For example, let's look at Ebola. I'm sure all of you have heard about it from various different sources. Now, the problem was not that the system did not work well enough. The problem was that we didn't have a system at all. Now, why such thing happened? Firstly, we did not have surveillance and data. That is, no group of epidemiologists wanted to go and understand the disease spread and its characteristics. Number two, we did not have a medical team ready to go, and we did not have a way of preparing the people. Number three, we were very slow in spending workers into the country for medical assistance. And number four, there was no one there to look at the treatment approaches, no one to look at the diagnostics, and no one to figure out what tools should be used. Now, the fact that these elements are missing, it is a global failure. Now, let's look at the numbers. Nearly 10,000 people died within a span of 428 days, and all were in the 3 West African countries. Now, this had a limited spread, and there are 3 reasons behind it. Firstly, there was a lot of heroic work by the health workers. They found the people and prevented more infection. Number 2 was the nature of the virus. Ebola doesn't spread through air, and by the time you are contagious, most people are so sick that they are bedridden. And number 3, it did not get into urban areas, and that was both luck and situation. If it was the case, the numbers would have been much larger. But this time, we are not so lucky. Now, we have a virus where people feel well enough when they are infected and they are able to go to a market or board a plane and then cause the disease to spread all over. Now let's look at a model of a virus spread through the air back in 1918. This was the Spanish flu. It would spread over the world very quickly, and you could see that there are over 3 crore people dead in only a span of 263 days. In December 2019, there was a cluster of pneumonia cases in China. Investigations found that it was caused by a previously unknown virus, now named the 2019 novel coronavirus. Coronaviruses have caused 2 large-scale pandemics in the last 2 decades. First, it was the SARS, that is the Severe Acute Respiratory Syndrome coronavirus, and then the MERS, that is the Middle East Respiratory Syndrome coronavirus. SARS first emerged in late 2002 in Guangdong province of southern China. As a novel clinical severe disease, it presented with a typical pneumonia along with fever, headache, and subsequent onset of respiratory symptoms including cough, dyspnea, and pneumonia. Being highly transmissible among humans, SARS rapidly spread to Hong Kong and other provinces across China and then to other 28 countries. By July 2013, it had caused 8,096 confirmed cases of infection in 29 countries, and 774 of which were fatal. The MERS epidemic emerged in the Kingdom of Saudi Arabia since June 2012 with a similar clinical syndrome to SARS, but seemingly less transmissible. Most MERS cases were independent clusters and limited to countries in the Middle East, particularly in the Kingdom of Saudi Arabia. The 2019 coronavirus initially occurred in a group of people with pneumonia who had been associated with a seafood market and live animal market in the city of Wuhan. The disease has since spread from those who were sick to others, including family members and the healthcare staff. So how is the disease transmitted? The exact dynamics of how the virus is transmitted is yet to be determined. But in general, respiratory viruses are usually transmitted through droplets created when an injected person coughs or sneezes, or through something that has been contaminated with the virus. People most at risk of infection from the novel coronavirus are those in close contact with animals, such as live animal market workers, and those who are caring for people infected with the virus, such as family members or healthcare workers. So let's see, how does the disease present? In a recent study by Yuan Wang et al., unique epidemiological and clinical features of the emerging 2019 novel coronavirus pneumonia, they suggest that COVID-19 is now classified as 4 levels based on the severity of the symptoms: mild, moderate, severe, and critical. Mild patients only present mild symptoms without radiographic features. Moderate patients present with fever, respiratory symptoms, and radiographic features. Severe patients meet one of the 3 criteria, that is dyspnea, the respiration rate is more than 30 times per minute. The oxygen saturation level is less than 93% in ambient air, and the PaO2 by FiO2 ratio, which is less than 300 mmHg, and this is a diagnostic criteria for severe respiratory syndromes. The critical patients meet one of the 3 criteria. First, they show respiratory failure. Secondly, they show septic shock. And thirdly, they show multiple organ failure. The clinical symptoms of severe and critical patients with COVID-19 resembled most of the SARS and MERS, including fever, dry cough, myalgia, fatigue, dyspnea, anorexia, diarrhea, acute respiratory distress syndrome, arrhythmia, acute kidney injury, various degrees of liver damage, and septic shock. The common symptoms of hospitalized patients with COVID-19 included fever, which showed 98.6% of the patients shows that, fatigue, and dry cough, diarrhea. Less common symptoms include muscle ache, confusion, headache, sore throat, rhinorrhea, chest pain, sputum production, and nausea and vomiting. Whereas the severe complications included the acute respiratory distress syndrome, anemia, acute cardiac injury, and multiple organ failure. Now, something important is that the median time for first dyspnea was 5 days. to hospital admission was 7 days, and to acute respiratory distress syndrome was 8 days. Now, COVID-19 cases can be differentiated into three different segments. Firstly, the suspect case. Secondly, the probable case. And thirdly, the confirmed case. Now let's look at the suspect case. Number one, a patient with acute respiratory illness, fever along with at least one sign or symptom of respiratory disease, for example, cough, shortness of breath, and also has a history of travel to or residence in a location reporting community transmission of COVID-19 during the 14 days prior to symptom onset. Or a patient with any acute respiratory illness and having been in contact with a confirmed or probable COVID-19 case in the last 14 days prior to symptom onset. Or a patient with severe acute respiratory illness, that is fever and at least one sign or symptom of respiratory disease, for example, cough, shortness of breath, and requiring hospitalization, and in the absence of an alternate diagnosis that fully explains the clinical presentation. If such things are seen, we say that it's a suspected case. For the probable case, firstly, a suspect case for whom testing for the COVID-19 virus is inconclusive. Or a suspect case for whom testing could not be performed for any reason. And lastly, we have the confirmed case, where a person with laboratory confirmation of COVID-19 infection, irrespective of clinical signs and symptoms. Now let's look into the strategy that should be followed to combat the COVID-19 virus spread. Now, firstly, the thing that a government should ensure is quick detection and diagnosis of imported cases of COVID-19 and rapidly stop human-to-human transmission. Now, priority should be given to regions with the highest risk and the lowest capability to respond. The immediate next step is to develop a state-specific COVID-19 preparedness and response plan for the next 3 months. Now, this should include, firstly, appointing a COVID-19 planning team to coordinate and oversee the development of the state's preparedness and response plan. And then they need to engage with national authorities or international authorities to identify appropriate coordination mechanisms and key technical operational partners at country level and also among the state level. Then they need to map out existing preparedness or response capacity and identify the key gaps based on the guidelines by the World Health Organization. Then they need to engage with regional level programs and donors to reprioritize and or mobilize resources and capacities to implement the state preparedness and response plan. And lastly, they need to establish the monitoring mechanisms to track progress, review performance, and adjust state preparedness response plans as needed. Now, to implement the strategy that I just said, we need to follow these 8 steps. First, the country level coordination, planning and monitoring. Countries should ensure that a national level coordination mechanism is established between key ministries and partners across all sectors and is in place, and that this coordination mechanism is conveyed in a timely manner. We need to have an incident management team who will be established for the preparedness. The incident management team has to ensure that operational plan is implemented, including engaging with donors and existing programs to mobilize and allocate resources. And also, they have to monitor the effectiveness of operational plan and measures as well as to assess their social acceptance. Second, the risk communication and community engagement. We have to implement the risk communication and community engagement plan for the COVID-19, where we need to prepare local messages and pre-test through participatory process, specifically targeting key stakeholders and at-risk group. involve local influences such as community leaders, religious leaders, health workers, etc. There should be timely dissemination of messages and materials in local language through adaptive communication channels. There should be transparency and feedback mechanism about all the information related to COVID-19. Then we need to have a surveillance, rapid response and case investigation. So we need to develop and implement a public health emergency plan at point of entry in a multi-sectoral approach. Now, when I talk about the points of entry, I mean the places from where any kind of baggage or any kind of people who can come from outside to our border. So we need to have procedures, staff, supplies and facilities should be put in place to interview suspect or affected person. We need to establish an access to designated national COVID-19 referral laboratories. If we don't have the facilities, we have to make a new facility or borrow it. We need to go for the infection prevention and control mechanisms. We need to have the case management, and we also need to look into the operational support and logistics. Now, investigation protocols should be communicated to healthcare workers and health facilities too. And lastly, we have to identify and support the critical functions. That is, so that if countries during a widespread outbreak of COVID-19, we need to see in water, sanitation, fuel, etc. And also, most importantly, we need to see the devices that is actually providing us the supportive care and the workforce who is actually working day and night. They should be protected and they should be given the most priority. Because if this breaks down, there will be a huge massacre among them. Now, towards the end of my presentation, I would like to share some of the success stories that we have seen. Bill Gates have been impressed by the governors across the country, including the James Lee, the New York governor, the government Mike DeWine. So I'd also like to share the strategy taken by the South Korea government for suppressing the COVID-19. Now, South Korea followed this strategy of trace, test and treat, the 3 T's. So the country has managed to keep its mortality rate at 1.4% by this strategy, compared to a global mortality rate of 4.34% despite an outbreak triggered by the activities of a religious organization in Daegu, Gangbuk, which contributed to a spike in confirmed cases in the late February. Now, the highest recorded number of infections on a single day in Seoul, where 25 million people live, was 75. But in Daegu, where only 2.5 million people live, there was 735 recorded infections in a single day. So let's see how they did stop this from the spread. In South Korea, the phase 3 started on March 12. Till now, they have seen a downward trend in cases, and there are no new sporadic new clusters of infections. Now, the first policy that they followed is one of complete openness and transparency in sharing updated information of new infections through the Korea Center of Disease Control, simultaneously with all stakeholders, including the media, on where, when and how the infections were discovered and investigated. Now, according to Dr. Lee, the key learning from the outbreak of MERS, that is Middle East Respiratory Syndrome, which I spoke earlier in 2015, and the result is that there is no confusion among the public about what needs to be done to avoid spreading the virus. Now, the problem that we are facing right now is that the public is not aware of such situations and they have no idea how to react. So no cities have been locked down, no transport closed, and international entry still open for some. Still they managed to do this. Now the second policy is containment and mitigation. Containment was started after the first case was identified in China on December 30th, 2019. And the focus is on identifying infected patients immediately and isolating them to interrupt transmission. Now, he says that they track all suspected cases, and mind you, they track all suspected cases and trace all the confirmed cases. So, Primarily through a social distancing campaign, they introduced that after the outbreak, and it was also decided to close all schools and to recommend voluntary restrictions, including to large gatherings and working from home. So the lockdown that we are facing right now is a very good idea to stop the spread of this COVID-19. Now, the third policy is the triage and treatment system developed as a result of the experience of the MERS outbreak. In any outbreak, the biggest challenge is the overflow of patients exceeding the capacity of the hospital staff. To overcome this, South Korea created compromising 5 isolation hospitals to take care of 19% of the cases designated critical and severe. The fourth policy promotes massive screening and fast tracking of suspect cases, underpinned by the accelerated production of emergency diagnostic kits with a weekly diagnostic capability of 430,000 persons in a week. Now, Dr. Lee said that the main weapon is the diagnostic kits combined with drive-through and walk-through centers. So they created drive-through testing facilities. They have created walk-through testing facilities where people could drive through their car and get the test done. They had an information system using the cell phones where they were informed if they had a negative test, they were send an SMS that your test is negative. And if they had a positive case, the government called them and did the procedures that needed to be done. Now, Korea has more than 100 labs working around the clock with a daily testing capacity of 20,000. And this has been crucial in keeping COVID-19 at bay. So at the end of the day, lockdown is something that is a very good decision taken by our government. But the next thing that needs to follow the lockdown is massive testing, because the more we test, the more number of cases we identify and the more number of cases we treat. And this is the only way to suppress this thing. To conclude, I would like to say that complete lockdown is a great initiative taken by the government, but tracing the disease is more demanding at this point of time. Every household needs to be screened for the symptoms, travel history, etc. Now, we have to involve all the state laboratories to form a united inventory for testing COVID-19. And government should provide the funding for all the testing. We have to increase the number of capable hospitals to treat COVID-19 patients. And we have to invite all the stakeholders for a unified team with the government to work and stop this epidemic. So from the epidemic that we are in, we learn that it's the need of the hour that we spend more on education and health. You have to make sure that your intelligence and realization is able to find the gaps, and that needs to be filled. Thank you. Have a great day. Stay safe, stay at home.